Hello, I'm Todd Didier, Senior Manager of Communications for the Primary Care Collaborative. Every month, the PCC recognizes leaders from across the nation who are improving the health of their communities by helping strengthen primary care. This month, we're thrilled to recognize Dr. Alin Severance, Medical Director of Behavioral Health Services at UPMC Health Plan and Associate Medical Director at Community Care Behavioral Health. Allen also serves as co-chair on PCC's Behavioral Health Integration Work Group and has been a longtime advocate for stronger behavioral health integration. Allen, thank you for joining us today.
Thank you very much for having me, Todd. It's quite an honor, and I'm a big fan of PCC's mission and vision. So I'm really happy to be here today.
Well, we are absolutely thrilled to have you here today, and I can't wait to hear more about the phenomenal work you're doing. And why don't we go ahead and start with how did you become a primary and behavioral health integration champion? And why are you passionate about supporting access to high quality, comprehensive primary care?
So my path to this point has perhaps been a bit more roundabout than others, as I am not a primary care provider, and I have no background in health policy per se. I'm a psychiatrist. And before working in managed care, my early career work was focused on providing psychiatric consultation within several academic medical hospitals and serving as a frontline psychiatrist for a county-wide behavioral health crisis service in the greater Pittsburgh area. So I've long been fascinated by the interplay between behavioral health and physical health, in particular, physical health conditions that can present with behavioral health symptoms, such as anti-NMDA encephalitis and many endocrine disorders, and behavioral health conditions that sometimes present with physical health symptoms, such as conversion disorder and even just depression. I've also witnessed how frequently fragmented care and the siloization of the various medical specialties, psychiatry in particular, can lead to needless delays in care and unmet healthcare needs. Well, UPMC Health Plan is somewhat unique in that our most recent president and current CMO are both expert behavioral health professionals themselves. So meeting the behavioral health needs of our membership is and has been a priority. I feel like I have a huge amount of support. It's also just one of the reasons why UPMC has been an executive member of PCC for many years now. And then being able to serve as the co-chair of the PCC's Behavioral Health Integration Work Group for the past 3 years has been really a blessing and source of inspiration as I learn about the efforts of colleagues throughout the country to bring together high quality behavioral health care in the primary care setting.
You touched on something that I'd love to dig deeper into, which is the interplay between physical and mental health. Could you tell us a little bit more about what role behavioral health plays in shaping a person's whole health?
Yeah, so there's a bidirectional relationship between people's mental and physical health. Many acute and chronic illnesses are associated with increased rates of depression and anxiety, and many behavioral health conditions are then associated with worse outcomes for many medical illnesses. And on the surface, this makes sense. Somebody who's depressed is going to be less likely to care for themselves, to seek care, or to follow through with medical advice. Serious mental illnesses, in particular, are associated with a 15-year reduction in life expectancy. And it's not due to suicide, it's due to common medical problems such as cardiovascular disease, stroke, and cancer. So, to borrow an analogy from a colleague, Dr. Matt Herford, instead of thinking about behavioral health as a slice of the whole health pie with other slices for physical health, oral health, social health, etc., it's more accurate to think of it as an essential ingredient, such as sugar or baking soda. The pie is not going to turn out as well if it gets neglected. So you might think that patients would benefit most when their mental and their physical health needs were being met at the same time in the same location. And you would be right. But the default actually is not integrated care in this country. Medicine in the US tends to be practiced in silos, with each specialty focusing on a particular organ or family of diseases. Psychiatry, in particular, has often stood apart from its peers, with details about patient care concealed by privacy concerns and confidentiality laws. So the status quo in many places is for primary care providers to treat what they can and to provide referrals for more specialized conditions or when the patients are not improving. But less than half of patients referred out for mental health services ever follow through. And as few as 20% of patients who are started on an antidepressant in a primary care setting experience a significant improvement in symptoms. So integrating behavioral health into primary care ensures that patients who might otherwise go without behavioral health services receive early assessment and treatment. It also avoids or mitigates the issue of stigma because it normalizes the attention to behavioral health. They don't have to go to some office. It can all happen. Nobody has to know. Um, and patients do have much better outcomes when this is the norm.
UPMC has been an industry leader in supporting behavioral health integration efforts. Could you talk a little bit more about what's motivated UPMC Health Plan to be so focused on behavioral health integration, and what can and should other payers be doing to foster stronger behavioral health integration?
Well, first of all, I'd like to sort of bring attention. There was a 2020 publication. This was mostly out of community care behavioral health, which is the medical assistance plan for the behavioral health carve out in Pennsylvania. And they, initially under a PCORI grant, designed a model of integrated physical health and behavioral health care, but not in a primary care setting. It was bringing primary care into specialized behavioral health settings because patients with more severe illness, their physical health needs are often not well taken care of. Um, and it was so successful that it ended up being expanded to multiple sites throughout the state. It was sort of a priority, and we invested to make sure that this got stood up. So I think it's important for payers to be aware of the realities that their primary care practices are facing, in particularly those who are dedicated to providing high quality integrated care. I know of multiple clinics throughout the country. Within our network, there are several, but I am aware of colleagues in Boston who have run into the same issues where the existing fee-for-service billing codes for the collaborative care model are just too cumbersome without electronic health record support, that they just abandon billing. And these clinics are sustained purely from the reinvestment funds of the clinic revenue itself. They believe that it makes a difference, that it's the best thing for their patients, that it's the best thing for their providers. People generally really prefer practicing in an integrated environment. Um, the alternative is a lot more stressful for most PCPs if they're sort of rushing from patient to patient under sort of more volume-based incentives. Um, but if we want this to be more widely available, um, and people aren't able to sort of reliably bill for it under the current dominant payment models, then payers have to adapt and make it sort of meet them halfway, have a different approach. So I think, in terms of what can other payers do, um, their need upfront investments are sometimes necessary to get things to change. And that can be challenging in multi-payer environments when you're just a quarter of the patients in a particular clinic. How do you change behavior? How do you change models of care if other people are not on board? Um, so to the extent that it's possible, making sure that our payment models reflect our priorities and intentions can go a long ways.
Obviously, we are entering a new administration, a new Congress. Obviously, federal policy and state policy plays an important role in setting our priorities at the national and state level. So, thinking about it from that angle, thinking about kind of what you just said about the importance of making sure our priorities are represented by our policies, if you could emphasize one major message to policymakers, thought leaders, other experts that kind of help shape these important conversations about primary care and behavioral health integration, what would it be?
I'm going to suggest two related messages. Message number one, much of clinical research is focused on what works. Comparatively little is focused on implementation. The figure I have heard is 10 years, that it takes approximately 10 years between when a particular intervention or model of care is established to be a best practice for whatever condition we're talking about, and when it becomes widely available. And this is just far too long. The original impact trial for the collaborative care model was published over 20 years ago in 2002. And yet adoption of the model remains slow, despite a growing evidence base to suggest that it and other models of integrative care are the best way to care for a whole person. Patients do better. It is more cost effective. There's often less burnout from the provider perspective. The message number two is that, in my opinion, every resident in family medicine, internal medicine, pediatrics, and psychiatry should have some experience working in an integrated primary care environment during their training. If you get exposure to a particular way of treating, whether it's a procedure or a class of medications, you're much more likely to continue that practice when you have finished your training. If you've had no exposure, it people might not be seeking out these jobs to the extent that they're being posted and they're available. It's just going to greatly accelerate any efforts to disseminate and to expand access to integrated care.
So we've talked about some real pragmatic solutions that could be implemented by policymakers, but sometimes what we want to do in the real world isn't necessarily our dream. So if you could wave a magic wand, if you could change one thing about the American healthcare system overnight by just waving a magic wand, what would it be?
I like this question. I've been asked it before. I think I would like to change people's expectations. I would like for primary care providers to expect that their patients to trust them with their behavioral health needs and to expect that they can effectively meet those needs in-house with the support of an expert team. I'd like patients to expect that their primary care providers can and will give their behavioral health needs the same time and attention as their physical health needs. And I'd like for payers to expect that integrated behavioral health should be the default in primary care and not the exception, and to expect that alternative payment models may be needed to promote and sustain team-based care.
That's fantastic. I think it's pretty hard to argue with that, and that's what it should be. We should be promoting an approach to care that people are able to have those expectations. So I think that's a phenomenal vision. Alan, thank you so much for joining us today. Thank you again for all your hard work promoting behavioral health integration and working with the PCC on this important issue. We're incredibly grateful to have you at our table, but more importantly, we're incredibly grateful to have you out there in the community helping advocate for important changes. So
Thank you
thank
so
you.
much, Todd.